Welcome all to session 1 in our 7th edition of AHBS, the role of the private sector in advancing men's health. I will start by making the following remarks. Everything costs something, and health, or the lack of it, is not an exception. When we look at health, we hear that Africa has the highest disease burden compared to all the other WHO regions. But what does this mean? It means that we record more than 7 million deaths per year. More than 630 million years of healthy lives are lost, and approximately $2.4 trillion are lost per year. That's a lot of money, if you ask me, and I believe we can all agree that that's a lot of money. But we can recover when we incorporate preventive and promotive strategies. This percentage of the money that's lost, that's 630 million years per year. 5 countries in Africa account for more than 50%, and that's Ethiopia, Democratic Republic of Congo, Tanzania, South Africa, and Nigeria. So why are we here today in this session? We want to embrace the culture of preventive and promotive strategies, and we need to know what we do this. Preventive and promotive strategies, so many benefits that you gather. The first one, of course, is the personal and social benefits. The effects of using a loved one affects many generations. The second reason I believe is the increase in productivity. People are at least 3 times more productive than others, and saving lives and saving resources. This balance to the question, how much do we need to invest so that we can see real change in the society? We have to be surprised to know that if we invest less than $1 per person per year, we will be able to save more than 7 million lives in the continent. And because of at this point, I want to welcome my decision that's national diseases in the Ministry of Health, Dr. Visha Patel from Mikisha Hospital, Dr. Visha, the chairman of Private Hospitals Association in Kenya, Mark business advisor for the Trans Health Network in Population Services Kenya. Who will be joining us online, who is the Vice Chair of Global Action on Men's Health. And please come to the stage. I'll hand it over to our moderator of the day, Dr. Marie, Head of Non-Communicable Diseases in the Ministry of Health Kenya, to take us through the session where we look at the epidemiology of African men. We'll also look at some of the barriers against why men do not seek medical services. This is a reported topic, so it would be great to hear from the speakers and also from the panel, from other participants on some of the reasons why men are not seeking medical services whenever that is required. We will also hear from speakers on what are some of the strategies that are being implemented in different parts of the government. We'll also touch and speakers on partnerships in preventive and promotive health strategies. Over to you, Dr. Marie.
Thank you very much, Catherine. Let me take this opportunity to say good morning. Mornings, once again, I'm sure we are from tea and the energy is not now an issue. Good morning. Thank you very much. As you've been told, I am Dr. Efantas Mare. I work with the Ministry of Health, Department of Non-Communicable Diseases. And my role this morning is very, very noble to moderate this session on preventive and promotive health as far as mental health is concerned. And with me, I have three panelists or three speakers who shall be talking to us this morning. I'm sure they have already been introduced. And let me just very, very quickly introduce them so that you may know who is who, because the mention of the name will help the person. It may not click very well. I want to start with the speaker closest to me. That is Brian Lishenga. Maybe you can stand, Lishenga, for the, yes, differentiated from the rest. Be seated. Thank you very much for being obedient. Dr. Brian is a physician and chairperson of Rural Private Hospital Association. Maybe once he comes to the podium, he shall tell us what that means. He's also the director, New Point Hospital. Next to him, we have Michael Mugo. Thank you. Michael Mugo is business advisor for Tunza. I'm sure most of us are conversant with Tunza. Family Health Network, Population Services International. Next to Michael, we have Vishal Patel. He's medical director, MP Shah Hospital. We shall also be having another speaker who will be joining us online, and that will be Mr. Amon Luhele, who is the Vice Chair, Global Action on Men Health. Having said that, let me go straight to the objectives of this session. And the objectives of this session, we shall be dwelling in depth as far as preventive and promotive health sectors is concerned. The role of preventive and promotive health comes to private sector in advancing men's health in Africa. We may not necessarily be able to split the air between and public when it comes to the presentation, but I would ask the speakers to really touch base on private issues. Having said that, I think it will also be good for us to touch base on what is promotive and preventive health in less than a minute. You are as far as preventive health is concerned. In preventive health, it is just that service we offer to the people in order to enable them take control of their health. Taking control of their health. What are we doing to our population to enable them take control of their health? Then, as far as prevention is concerned, it is basically taking measures to control diseases and disability. And when I talk of control of diseases and disability, there are many areas of prevention, including biological, like genetical, also including those factors within our environment. So without much ado, I want to begin the process of the presentation by our speakers. Some will present by giving a speech, and others will just give a talk. Each speaker will present for around 10 minutes. We'll allow all of them to give their talk. Then we shall have a plenary of around 35 minutes. And I want to believe that is agreeable with us. Is it agreeable? Or we give plenary more time? Okay, thank you. I want to believe that is guided democracy. So, yeah. So we'll start with our first speaker, who is Dr. Brian Lishenga. He shall be talking on us on epidemiological profile of men in Africa and men health-seeking behavior in Africa. So, karibu, Dr. Brian. You may choose to sit or you can come to the podium, but I think the podium is much, much better. Thank you. Thank you.
All right, thank you, Dr. Murray. Brian, morning. My name is Brian, as you've heard. I am very pleased to be here and to see many faces I haven't seen in a while. I see some of them on social media only, and then gives the false perception that I have been seeing you for a while, but it's been a long time. Well, as Dr. said, I am the chairperson of the Rural Private Hospital Association of Kenya. Our acronym is RUPHA, Rural Private Hospital Association of Kenya. I'm also serial health entrepreneur, just been doing healthcare business for a long time, since about 2010, 2009. Some of them successful, some of them fail miserably, but still keeping at it. I have also been in academia. My last formal employment was with Egerton University for about 13 years. I was lecturer in the School of Medicine, and my last job was as Dean of the Faculty of Health Sciences. But my most recent job was as a candidate for the Senate in Kakamega. That was my most recent engagement. Thank you for all of you who supported me who are here. I managed to come a strong second, and we want to fight another day. So thank you, must say that. So I have been given the opportunity to talk about epidemiology of the African male. This was, I told Catherine, this is a very difficult topic because we do epidemiology of cancer, epidemiology of diabetes, but now epidemiology of the African male is a little difficult. I had trouble finding studies to support. So if my presentation looks like it is all over the place, it's exactly how I felt when I was when I was researching this. But I only had 4 slides, and I'm going to try and just provoke thought, just provoke your thinking. Now, so my background is medicine. So a lot of this will come from that background. One, we have many studies, and you can check in your free time, that show that in neonatology, so this study of the newborns, that male gender is associated with increased mortality and morbidity. This is a fact, especially if you've been to School of Medicine, pediatric rotation somewhere in the neonatal unit, male babies just die. They literally just can't fight as hard as the girls. So this is well known. Poorly understood why baby boys die more than baby girls. There are theories around it. For instance, is what is called the sex chromosome theory, which is the Y chromosome is a deformed chromosome It's lacking one limb. So this is going to confer some weakness to the male gender. This is one. The other theory is the evolutionary theory, which is that the sex ratio in any given population should be retained at 1.0, so 1. And however, for human being, Homo sapiens, at conception, we tend to produce more boys than men at conception. I'm not saying at birth, at conception. So nature has a way of correcting this to a ratio of 1 by making sure baby boys die. So that is the evolutionary theory. But I put a caveat there and say that this aspect of baby boys dying more than baby girls is poorly understood. So those of you who fancy research, this is something you can look at. So now we established that as a baseline. Being born male is a risk. You're likely to die. We have a study, another interesting study I found, 2004, a study which looked at demographic and health surveys in 10 African countries, including Kenya, Uganda, and Tanzania. We were part of that study in 2004. So what was interesting from this study is that they looked at children under 5, and in those 10 sub-Saharan African countries, male children below the age of 5 were more likely to be stunted in growth than baby girls. So this is there. You can please find me for references later so that you don't accuse me of just data out there. So this study is there 2004. We have a study in 2007 that was done in Ghana, Tanzania, and Uganda and Norway, which showed that the single consistent predictor of a road traffic accident was being male. So just being a guy, you are likely to cause accidents. And we know that road traffic accidents right now have reached, it's a catastrophe in terms of the number of people we are losing in road traffic accidents. And the likelihood that the person who dies is male is extremely high. The odds are extremely high. We have a study in 11 East African countries. This is also 2007. That looked at substance abuse and found out that 43.7% of males in these sub-Saharan countries abuse some substance of some sort. So about 43%. So they are abusing something of some sort. And the predictors for what they abuse included things like education level. Now this was interesting. So you have a peak where the education level is low, what we are talking about basic or none. So primary education or none, higher risk for substance abuse. And then it tends to go down when you have secondary level education. And then it goes back up when you have more than secondary level education. So that is education. And then age, the interesting thing is we think it is our younger men who are abusing substances more. It is true. But what these studies have shown is that the African male, as they grow older, abuse substances more. Marital status, this one should be obvious. If you are single, divorced, separated, male, likely to abuse substances. Current job status, being unemployed. And even the country you are coming from. So if you are in East Africa, if you are Kenyan and you are male, you are likely to abuse substances. So Kenya is leading in East Africa. Now, one of the things that interested me is why does substance abuse increase in males with advancing age? This interested me because we know advancing age and male gender predisposes you to coronary vascular diseases, cancers. So I was really interested on this. Why are they, as you grow older, as men grow older, they are abusing substances more. And some of the identified reasons include one, bereavement. Obviously, as you grow older, more people you know, more people who are closer to you die. This is natural. So they are experiencing bereavement more. So many of them are latching onto substances as time goes by. Social isolation, the lone wolf scenario, lack of social support. A lot of men are not looking for social support, and financial difficulties as they grow older, retirement and things like that. So all these factor in, and being divorced or becoming a widower, this also factor in. Now, this was interesting. Two last ones which I found interesting in the epidemiology. One, in Africa, this was a study. This is very recent. This was published in May 2022. In Africa, 24 countries, the likelihood that being male increases the risk that you will be breastfed later. So this was very strange. So just being male increases the risk that you will be breastfed later. So we have this early initiation of breastfeeding. We know that if you initiate breastfeeding within the first hour after delivery, increases the risk of neonatal morbidity and mortality. But I have a study that was published pretty recently in PLOS, and they looked at 24 African countries. Unfortunately, Kenya was not one of them. And an interesting finding was that being male, the likelihood that breastfeeding will be initiated later is higher. And especially the country with the highest disparity here was Togo. So in Togo, the difference was massive. So baby boys were going up to 12 hours, 24 hours before they get initiated breastfeeding in Togo. Now, the study didn't go into why they are doing that. It's just descriptive. So this is the country that was most equal was Guinea at 0.48% difference, but still there was a difference. The other one that I found interesting was we're just coming off the heels of the COVID-19 pandemic. And so this was not in Africa. This was done in the Duke Health System. And they found that being male was associated with less likely use of telemedicine for a consultation. So, we moved a lot of healthcare to tele during the pandemic. So they found that being male, they don't want to consult on phone. They don't want to make that video call. And especially being male and Black. This was even higher risk. So back here in Kenya, cancer, and I looked at non-gender cancers. Now, these are obvious statistics. Daktari from NCD, you will confirm that lung cancer is 3 to 4 times more common in men. Colorectal cancer is 2 times more common in men. Stomach cancer is 2 times more common in men. Liver cancer is 1.5 times more common in men. On health-seeking behavior. So there's a growing body of evidence that men delay seeking help for health problems. There's now a body of evidence that shows that, whether it is for depression, substance abuse, physical disabilities, or even stressful life events, we have a whole body of evidence that shows that men delay seeking help for this. Now, some of the theories, again, a very poorly understood area of health sciences, is why are men behaving like this? But we have some theories. For example, what is known as the traditional masculine behavior. So there's a very interesting phrase here. It is called hegemonic constructions of masculinity. What do I mean? So this is simply the defined, successful, and dominant ways of being a man. So defined, successful, and dominant ways of being a man. So this is where the theory is right now, that we have some definitions of what the male construct is that have something to do with the failure of health promotion strategies targeting men to seek healthcare. But I don't think this is a problem that is affecting men only. It's also, these constructs also affect the female gender, because I've given you examples where it is moms who initiate breastfeeding, but they are initiating it later. So that can't be because they have some masculine construct of how a man should be. Should provoke how we think. So there's an urgent need for work that takes masculinity and gender roles into account. In other words, maybe we need to start asking ourselves, what is it? What is being a man? What really is being a man, and redefine it. And we need to start embracing the concept of multiple masculinities. There is not only one definition of being a man, there are many definitions of being a man. Thank you.
Another round of applause for Dr. Ari. Thank you very much. I was just about to raise the red flag. You've taken 10 minutes, but since that was the introduction of the subject matter, I didn't want to interrupt you. And you have brought it up very, very well. The profile, epidemiological profile of an African male. You have also talked of the socioeconomic factors associated with the male child as far as disease burden is concerned. You brought up the issues of substance abuse, but I'm very worried because you've indicated as we grow old, and I'm among the old, as we walk out, I don't know whether that is very, very true, but that's subject for discussion. The more we are abusing substance here with Dr. Wale, yeah, then apart from that, you've also indicated why men are prone to developing some conditions because of the conditions they go through. And this has reminded of yesterday, I was at Kisumu with the First Lady who is with us here today. And we were launching a clinic on blood disorders. And as we did that, a lady approached me, a champion of sickle cell, and told me, Dr. Mare, I know tomorrow you'll be in a certain forum. Please don't forget to mention about male circumcision. For quite a number of our men who have blood disorders, we are losing a number of them in this region. And then she told me, number two, and very important, as a sickler, or us with sickle cell disease, let me not use the word sickler. When our males are in crisis, they normally go through very painful erection. And I want to say I'm happy that I've delivered that message today, and the First Lady is my witness. Thank you, thank you. Our second speaker, that was on a light touch, but on a very serious note. The lady is the one who was concerned about men, and not men concerned about. That goes fast into telling ourselves about men health seeking. It is a lady speaking for us. We are not speaking for ourselves. Thank you. Our next speaker is Michael Mugo. Michael Mugo will be speaking on barriers affecting men health-seeking behavior. Karibu, Michael, 10 minutes. I know I've taken you 2 minutes, so you have 8.
Yeah. Thank you so much. Hello, everyone. Michael Mugo is my name. I'm a business advisor for the Tunza Social Franchise Network. That is a network of right now over 400 clinics spread around the 47 counties in Kenya. We work both in rural and urban centers. I don't know, we've never met. We're taking all of facilities right from level 2 and level 5. Facilities that are level 5 facilities, but a good majority are between level 2 facilities to level 4 facilities, offering primary healthcare services to the communities that were located. My presentation is about barriers affecting women. I think I was sick after this, don't schedule it. Because WHO was a second around what WHO has done with the studies. So I can't speak after the Director General has spoken, but it's true. From my research and what I've found out, the men don't generally go to hospital. They don't have very good health-seeking behaviors, and it's much far less in Africa. And like the DG said, at 63%, we're not doing so well. So, of course, kudos to the organizers of this organization to just, this conversation needs to start happening. Has caught somebody else. Maybe they've brought the wife, they've brought the child, they're caught. If you ask why they're not doing the service, I mean, if I put myself into the facility, I'm fine. Internally. So that I came to find out that was affecting political behavior was masculinity. There's no, I think locally here we say mwanaume ni kohozi. No, lazima ikuwe hali mbaya kabisa ndio kuwa unaenda hospitali. I hope we are all understood. So it's till the last minute. It has to be pretty serious for you to go and get medical attention. So that is the biggest barrier to men accessing health. And we need to revise our standards of what is masculinity. I think just like the Ministry of Education is revising the curriculum, we need to also revise our understanding and our standards of masculinity. I don't think there's anything wrong. We need to welcome, to express ourselves. There's there's nothing wrong with being vulnerable as a man. There's nothing wrong with seeking help. There's nothing wrong with being sensitive. I'm trying to find a language of expressing ourselves, because that is the main reason why we don't go to hospital. Again, even in the Tunza social franchise, we do organize a lot of outreach activities. We try as much as we can to do approaches. This cancer screening, some cancer screening, and prostate cancer screening. The Tanzania work. I've never been in an outreach where we've recorded double digits attendance by men for whether breast cancer screening, because we need our clients to go to breast cancer screening, or even prostate cancer. As recently as March, we were Kisumu, my first lady is here. We were in partnership with Stanbic Bank. We did breast cancer screening and cervical cancer screening. We integrated with prostate cancer screening, and I will tell you from as recent as March of this year, we got, I think we were able to screen over 1,000 women for both breast and cervical cancer screening, but only screened 5 men. And this was an outreach that we did over a period of 3 days across breast cancer and cervical cancer screening. That also affects men was also the lack of information, because they thought that prostate cancer screening is a surgical procedure. So there was that skepticism from them. How are we going to get screened out here in the field? So after going through the conversation about it's just a quick through blood, you can be screened. And then if a client has anything, we can be forwarded for further consultation. So language, sorry, not language, information barrier, where most men don't know what they're exposed to and how they can ask for help. The other thing is also that we have recorded around. So now that my speech was written all over by other speakers, and I want to take you through the same conversation. For primary healthcare, religious and cultural beliefs. I think during break I was just talking to Dr. Patel, and he was telling me of a story that happened up in the north. Fantastic outreaches. They did not show up. But after a small organization with the community leaders, it was organized that the men can come late in the evening, and we got very good numbers. So because during the day, the men are out there cultivating the land, they're out there hunting for their animals. So some of these cultural and expectations on the men also hindered them to access some health services and take care of their well-being. Peer influence, again, just feeding into masculinity. It's if I will know I'm early from this thing, I will appear to be weak. So I will shy away from seeking good healthcare. So because I don't want to appear to be weak, so over the conversations and the introductory remarks that we received, it's not visible that the levels of seeking behaviors in men affects their health outcomes, because you're going to seek help pretty late in that element. There are more previous interventions that need to happen to just take care of you, as opposed to when you could have searched for help early enough, and the entry-level interventions that
Coffee tena. Thank you. You really kept time, 8 minutes. So the 2 minutes I used from you are recovered. You've put it very well. We have heard what barriers do exist, socio-cultural, masculinity, to feel that you are the man. Yeah. And in Swahili tunasemanga mwanaume ni sauti. I don't know whether we are using our sauti appropriately. When I look around this room, and I didn't have an opportunity to attend the last forum, which was advancing women health in Africa. I have no doubt 3/4 or 80% of the participants most likely were females. So wanaume wenzangu, if you look around you, the ratio is 1-to-1 or even less. So some of these things are even showing wherever we are. Now we are going to have our third presenter who will do it online. Hope the IT team, you are okay. Dr. Vishali would be the fourth one, because we want to flow it in a certain, through certain thematic areas for ease of our understanding. So now it is a chance of Amon Muhele, hope I'm pronouncing it well, to take us through preventive and promotive strategies employed in Africa to improve men health, including men health seeking behavior. So, Amon, the floor is yours.
Yeah, thank you. Thank you, the moderator. I need to have a slide.
We seem to be having issues with sounds. Can you unmute?
No, I'm not mute. I'm loud and clear. But I think to our side, there's an issue of technical in terms of sound.
Uko sawa sawa sasa. Aaron, please.
All right, but I need Catherine to share the to share me the presentation. Catherine, please. So my name is Amon Lukere. I'm here representing the Global Action on Men's Health. This is a network of organizations based in the UK. I'm the vice chairperson for the network itself. So I would like first to thank Peter, the director for the Global Action on Men's Health, and the chairperson as well. So the Global Action on Men's Health launched in 2014 and become a UK-based international charity in 2018. An international network with over 60 organizations and individual members. Mostly national men's health organizations, research and advocates institutions are part and parcel of this network. So in Africa, we're about 6 countries, also some of the institutions are members from those sides. So our mission is to create a world where all men and boys have opportunity to achieve the best possible health and well-being where they live and wherever their backgrounds. So as we go, our main goal is to influence policy at the global and national levels. Next slide, please. Next slide. All right, so we focus primarily on public health and social determinants of health and equity. Global Action on Men's Health on a broad and cross-cutting range of men's health issues. We have so many issues around that. As you know, other speakers already spoken about that. Issues of health literacy, risk-taking behaviors, and other services. So we also looking at strengths-based view of men's boys. We also believe that men should be held accountable for unacceptable behaviors, including gender-based violence. So there's a lot of issues around gender-based violence, which we are also focusing on. Again, we support an approach to health and ethics that takes full account of sex and gender in order to improve the health of both men and women. We also encourage the networking and collaboration. So next slide, please. Next slide. Next slide. Okay, so we just maybe point out some few problems, and others are already pointed out. So male life expectancy, according to WHO Africa region, I think by 2019, this was the statistics, 62.4 years. I think that's the expectancy of the living in this earth. That is that. Male health life expectancy, 55 years, and but government and the development partners show little interest in taking action to improve men's health. So there's a lot of issues. Only South Africa, South Africa and Africa, I think they're doing enough in terms of having the policy on men's health. So that is that. Now we go to men's health, Global Actions on Men's Health Organization in Africa have identified the following priority areas. So we've got violence by men and against men, cancer issues, issues of mental health, and the issues of TB and HIV and AIDS, and issues of substance abuse that are also taking stage amongst men's health issues. Next slide, please. Next slide. Yeah, so we are looking at the solutions that the proposal, and as regard to solutions, the WHO Africa region should take a read following the example of the European and American and the Western Pacific regions, a regional report on the state of men's health would be a good starting point. So our friends there, they're doing enough, they're doing something on that. And in Africa here, I think we are not doing enough, for Southern Africa including, we are not doing enough. So greater technical and financial support is needed from government and development partners to civil society organizations to do awareness raising and others. And we are also looking at more men's health policies are needed, and the men's health should be included in the health policies. So then we have got an issue of one specific action that could be taken in field of cancer prevention. That is very important. Issues of gender and the HPV vaccinations are also important. And men's health days are supposed to be also taken place. And workplace are an important setting for men's health activities. So we are supposed to have all those things as the men's health agenda in Africa. I would like to say thank you, the moderator. This is the end of my presentation. Thank you.
Thank you very much. I think my speakers are doing very well. That one has saved around 3 to 4 minutes or so. And I think we are quite on course. He has talked on a number of issues which we need to do when it comes to strategies to address men's health. One of them being policies. We also need to do on something on GBV, gender-based violence, drug substance abuse, mental health. There are more mad men than women. Yeah. Cynically. Workplace wellness, and maybe before I forget, we can just wave a team to say we appreciate that we are appreciating your presentation. Asante, he has acknowledged. Great. Our last but not least speaker is Dr. Vishal Patel, Medical Director, MP Shah Hospital. He is going to take us through partnership in multidisciplinary care in promotive and preventive strategies for advancing men's health. Karibu, Daktari. And I'm told we keep the speaker a bit far because I think our record was vibrating so much.
Thank you, Dr. Murray. And my name is Dr. Vishal Patel, as said. I'm the medical director at MP Shah Hospital. We are a private healthcare provider here in Nairobi, for those of us who are not from Kenya. And we have been in the private sector providing healthcare for the past almost 80 years. From what the speakers before me have said, my co-panelists, the data is very clear. I wouldn't want to repeat it, but the most important message that has been put out that we have seen men's life expectancy and health life expectancy, more importantly, it's dwindling, it continues to dwindle. And I think forums like this and conferences like this are what is needed more. I see a lot being done for many other health issues, but the one looking at men's health have been far-fetched, and we are glad that we get to be a part of this. Then when we look at what has been given in terms of the data, not just epidemiology, but also looking at what is affecting men's health, what's contributing to the morbidities, mortalities, and overall health and these dwindling numbers. From there, you can see it's multifactorial because it's not just one. We're not talking about that. It's just prostate disease or prostate cancer that has a very significant burden, and that's what's affecting men. No, it's a lot. If you see the number one cause, it's cardiovascular disease, and that is more of a pandemic right now, then it will claim more lives more than any other infectious disease pandemics. So when you look at it, apart from cardiovascular disease and prostate that are looked at most importantly, that are classified as unintentional injuries. These are mostly road traffic accidents or other accidents operating machinery, etc. And again, that is one of the leading causes for mortalities in men. And as said as well, health seeking behavior is very, very poor. We've been talking about the concept of masculinity, among other things. With this multifactorial problem, definitely more is needed to look at how we can partner, how we can look at approaching this from multiple facets. And when it comes to preventive and promotive health, you have from your own countries within Africa have this experience as well. Many countries, the government and public sector, so there is a lot of work that has been done, that continues to be done to try and improve health, to try and make sure that the population is becoming more healthy. But in many countries where especially the national health system or health provision may not be as strong or may not have as many resources, you find that the private sector sort of takes the lead in providing high-end or up-to-date curative services. And that is the case, that has been the case here in Nairobi, where you would find that many of the private sector healthcare providers, larger hospitals, take the lead in trying to bring in the technology that is required to provide those curative services. But that alone is not important. I think for very long, resources have been poured into the private sector to try and, get the best cath lab in town, or rather the cath lab that's able to handle all cases, to get high-end cardiologists, technicians, etc., to try and create centers of excellence, to try and become market leaders in provision of these services. But that alone, we are seeing, is not enough. Then slowly we've gotten more into promotive health. We're trying to, again, look at how can we make sure that we're not getting these patients and these men at the time when they're getting that heart attack. Are we trying to empower them? Are we trying to make sure they take charge of their health and are not getting to that level, are not getting to be on medication for hypertension, diabetes, but rather are taking charge of their health and making sure that they get to that level. But that has again been done somewhat with the private healthcare sector, where, for example, you find some provided that try and empower, or try and at least empower men to try and take charge of their health, make it more enabling for them, make it more accessible. However, it's still not enough. Majority of the private healthcare sector, especially with the larger facilities, run on cases that are insurance based. And when we look at that, we of course are missing out on a lot of men and patients who do require this promotive health as well. And we're glad that there's much more being done, not just at the national, but county levels, facilities like KOTRH, with all the partnerships also becoming centers of excellence and making sure that they do their bit in providing this care. But when now it comes to preventive healthcare, we find the focus of private healthcare providers, private healthcare facilities, there isn't so much that many would do when we look at preventive care. And one of the things where I think partnership is required more is in this area. There are lots of enablers, forums like this. There are lots of NGOs that are coming up. There are lots of other even private institutions coming up, who are becoming enablers, who are becoming the link between the policymakers and the private sector who are becoming the link between the public, or rather the population and the private sectors when it comes to doing prevention. When we look at what is required, it is clear. When we look at the multifactorial approach and multidisciplinary care, that is also clear. What's required more is trying to make sure that people are leveraging on each other's strengths. We don't need to reinvent the wheel. We need to look at, we could have a center of excellence in a particular area, and how can the enablers for preventive and promotive health, together with the Ministry of Health, together with the public sector, how are we able to leverage on that strength? So, for example, the ministry has very good networks and very strong in prevention and promotion with community health workers, among other resources, which private hospitals don't necessarily have on with them, or they would not be a priority for them. So how can we leverage on that strength from each other to try and do more for preventive and promotive health? But I think that again can only happen when we have a common goal. And the common goal has to be aligned, has to be similar. And number two, there has to be sort of a situation, or rather a win-win situation for all the parties involved, in terms of just making sure that whatever is being put out in prevention and promotion remains sustainable. Because, for example, yes, we were talking about camps do help in this preventive and promotive medicine, but when it is done just as a one-off, no follow-ups, etc., it's not serving its purpose. It needs to be sustainable. So any partnership that comes in has to be more sustainable. Having said that, we also need to look at how can we make sure we reduce the burden of this multidisciplinary care on men who require it. Because take an example of someone going to the clinic, and sometimes you'd find, as my said, you may have to be, a man has to be very, very sick, or very ill for them to go to by the time they're going to hospital. Either that, or they're having a sexual dysfunction. I think those are the two main things that men have been seen generally to be seeking healthcare for. And typically you would get someone who maybe has decided, I need to get help for a sexual dysfunction problem. But you'd find even by the time a man gets to that point of where they need help, it's taken some time, it's taken a lot for them to come. On top of that, you need to have an enabling environment where they'll be comfortable coming in, they'll be comfortable talking to the healthcare workers. When this man is examined and the major problem seen is perhaps cardiovascular disease, hypertension, diabetes, and that's what's causing the sexual dysfunction as a secondary function. If this man is told, we have identified this, but we've also identified your pressure is not in check, you're diabetic, you need more A, B, C, D, E, F, G, millions of tests, specialists, nutritional counseling, exercise counseling, things which, yes, are important, are required. But we need to make sure that we are enabling and making this as seamless as possible for them, try and create multidisciplinary care centers, whereby if someone is coming and requires multiple consultations, they're getting them and they don't have to move from office to get that done. Can we look at leveraging on technology to make sure that this multidisciplinary care and individualized care is provided? Can we try and also, at the same time, make sure that we are empowering and educating the men enough to make sure that they are involved, there's shared decision making when it comes to our health and their health. So with that, I think it's very clear. We know what needs